Good morning, everyone. My name is Przemysław Witek. I am endocrinologist from Warsaw, Poland. I represent Medical University of Warsaw. In the beginning, I would like to thank you for invitation here, for the possibility of being here personally to the head of Croatian Endocrine Society, Professor Canecki. It's a great pleasure for me to be here with you. I'm going to talk about Cushing syndrome, especially about Cushing's disease. My presentation will be based on the recent consensus and the guideline. The first author is Maria Fleszeriu. This is the guideline published by Pituitary Society, and we all know this guideline. In the beginning, we can see screening tests which are commonly used in the initial diagnosis of Cushing syndrome, and they are pretty much the same as previous guidelines. So if the clinical probability of hypercortisolemia of Cushing syndrome is relatively low, this is usually enough to perform one of screening tests, either late-night salivary cortisol or urinary free cortisol, or overnight dexamethasone suppression test. If the clinical likelihood is higher, we usually need to perform at least two tests. In the department I currently work in, we usually perform all three tests in the initial diagnosis of hypercortisolemia. So here we can see that especially if we look at the late-night salivary cortisol, the both sensitivity and specificity of these tests, they are really very high. So this is here very important. If we look on the lower part of the algorithm, which is the important part of Pituitary Society consensus, we can see that the imaging diagnostic of the Cushing syndrome is also very important, and especially if we have the patient with the maximum tumor diameter which is visible on MRI examination lower than 6 millimeters, this is important to refer our patient to the invasive radiology facility just to perform inferior petrosal sinus sampling, if this is of course available. This is not available everywhere, but this is of course the best solution. If the tumor is bigger than 6 millimeters, this is not obligatory, but sometimes this is advocated to do that, just to avoid situations which are possible, just to diagnose Cushing's disease in a patient with ectopic ACTH production plus pituitary incidentalloma, which can happen during our diagnosis. In the second part of my presentation, I'm going to talk about medical treatment, especially steroidogenesis inhibitors, because this is the area of really huge progress in course of last 10 years. So I will talk about levoketoconazole, about the also about oscillodrostat, which is very potent steroidogenesis inhibitor, both based on the clinical trials, but also real practice clinical data. In Poland, we use oscillodrostat for even more than 5 years, so I would like to share also our Polish experience with you. We know that Cushing's disease is the most common cause of endogenous hypercortisolemia. It's responsible for about 70% of cases, but also ectopic ACTH production in patients with small cell lung cancer or neuroendocrine tumors. Such the causes are responsible for about 20–25% of endogenous hypercortisolemia. And the adrenal tumors, this is the rarest cause of Cushing syndrome, and this is usually benign adrenal tumors. Sometimes, of course, it can be the adrenal cancer. Cushing's disease, so the most common cause of endogenous hypercortisolemia, this is a very rare disease, but if we are unable to control hypercortisolemia, either by curative surgery or by using our medical therapy, we are going to lose even 50% of our patients in course of 5 years. So there is really very, very high mortality rate in Cushing's disease and in Cushing syndrome at all. We all know clinical signs and symptoms of hypercortisolemia. We know how hypercortisolemia can change the physical appearance of our patients, but we are also aware that if they have clinical consequences of hypercortisolemia, sometimes if they die because of hypercortisolemia we are unable to treat, they are going to die because of cardiovascular and metabolic complications, which are strongly connected with each other. Here we can see that morbidity and mortality in Cushing's disease is really very, very high. The risk of pulmonary embolism is even 7 times higher as compared to general population. The same is with congestive heart failure and also acute myocardial infarction. For that reason, one of most famous American endocrinologists in the area of pituitary disorders, Shlomo Melmet, called Cushing syndrome, Cushing's disease, a truly metabolic malignant disorder. And he also stated that if we are unable to control hypercortisolemia, in fact, the prognosis is the same as in 30s when the Harvey Cushing operated his first patient, Mini G. The treatment of choice in Cushing's disease, this is of course a transsphenoidal selective adenomectomy performed by an experienced neurosurgeon, and the effectiveness of such a treatment is the highest in case of precisely visualized microadenoma, smaller, lower in cases of macroadenomas, and of course the lowest if we are unable to localize the tumor. If our biochemical testing, our stimulation tests even clearly show that this is the pituitary problem, but our neurosurgeon is asking, where is the tumor? I can see the tumor, so he performs the cellular exploration. Sometimes this is curative, but sometimes no. The effectiveness of such a cellular exploration is definitely the lowest. But even if pituitary surgery is initially successful, we can expect, even in cases of 20–25% of patients, we can expect late recurrences of Cushing's disease, even many years after initially successful transsphenoidal surgery. So the real question is, how should we deal with non-cured patients or with patients with the recurrence of hypercortisolemia in Cushing syndrome, especially in patients with Cushing's disease. So according to previous consensus by Endocrine Society, we still have the option to perform either second or even third pituitary surgery, but if the first surgery was not successful, was not curative, the probability their second or third surgery will be curative is usually much lower. We have the possibility to perform to refer our patient to radiation therapy, nowadays especially to radiosurgery methods such as CyberKnife or Gamma Knife. Of course, we still have the option of bilateral adrenalectomy, which is the final very difficult decision in very severe cases. But in this area of medical therapy, we have really a huge progress during last 10 years. According to Endocrine Society consensus, the goal of treatment with medical therapy is normalization of cortisol production allowing for improvement and ideally normalization in cortisol-induced comorbidities. But the real question is how to achieve this goal, and of course, which drug will be the best, is going to be the most effective. If we look at pituitary society guideline, we can see here the first described drug is ketoconazole, the old drug, which is not so easily available in Europe, with the effectiveness on the level of about 60% in retrospective trials, but we are also aware that there are a high probability of side effects and also the risk of escape phenomenon in case of ketoconazole. The next medication, relatively new, registered 3 years ago, is oscillodrostat. I will talk about this medication in the second part of this presentation. We all know meterapon, which is also very good medication, which should be used at least three or in majority of patients 4 times daily. And in retrospective studies, the effectiveness of meterapon in terms of normalization of urinary free cortisol is very high, about 70%, but in recent prospective trial, this is definitely lower. This is lower than 50%. We know mitotan, which is reserved for adrenal carcinoma, adrenal cancer. We know also etomidat in very severe cases connected with psychiatric problems, very severe, very high levels of cortisol. Sometimes, if we have the easy access to intensive care unit, we can use etomidat. And also, there was levoketoconazole. We really hoped, Professor Atanaska-Elenkova is here with us. We participated in the clinical trial with levoketoconazole. We really hoped that this medication would have a greater, higher clinical effectiveness in terms of normalization of urinary free cortisol with lower level of side effects, but the clinical trial showed that only 30% of patients after 12 weeks of taking levoketoconazole normalized urinary free cortisol. Of course, we have pasireotide LAR formulation, which is registered for the treatment of Cushing's disease, but the effectiveness of pasireotide LAR is about 40%, especially this medication works in milder forms of ACTH-dependent hypercortisolemia with a lower concentration of urinary free cortisol. Here we can see the registration trial of pasireotide LAR formulation. So this is only 4 out of 10 our patients normalize urinary free cortisol excretion. And there is also some expense of that. This is the deterioration of pre-existing diabetes or hyperglycemia if the patient is not properly prepared to pasireotide LAR introduction. In Poland, in my department, we have several patients treated with pasireotide LAR. The doses are different between 10 to 40 milligrams. And if we can see here, majority of patients, they are taking anti-hyperglycemic medications, especially GLP-1 agonists plus metformin. In several cases, also, they are taking insulin. So who is an ideal patient for the treatment with pasireotide? Optimally, the patient with mild to moderate hypercortisolemia, of course, when pituitary tumor is a significant problem, and this is the problem for about 10% of patients with Cushing's disease, with corticotroph tumors. Ideally, patient without diabetes, or if diabetes is present, it should be properly controlled, and the patient should be prepared to pasireotide LAR introduction. If we come back to the Pituitary Society guideline, there are several points we can see there. and factors which are used in selecting the ideal adrenal steroidogenesis inhibitor. This is rapidity of action, good tolerability, easy of use, degree of likely biochemical normalization, specific clinical improvement, and also, which is very important here in this part of Europe, we need to think about the possibility of reimbursement of such a treatment, who is going to pay for such a treatment, because if we offer to the patient very expensive drug, probably the patient will not be able, without the help of the health provider, to pay for the medication. So if we look at the other medical treatment possibilities, I was talking about levoketoconazole. This is the paper taken from the registration trial, and very, very low normalization rate, only 30% after 12 weeks of treatment. And in 2022, in JCM, one of registration papers was published, and the conclusion from this paper, it was the registration paper of osilodrastat. The conclusion was that osilodrastat rapidly normalized mean urinary free cortisol excretion in most patients with Cushing's disease, and maintained this effect throughout the study. And also, the important issue was that the safety profile of this medication was also favorable. Here, if you can see the yellow color at the end of steroidogenesis process in adrenals, this is the place where both meterapon and osilodrastat are working. So the final steps of both aldosterone and cortisol production. If we look at the registration paper, 66% of patients normalized urinary free cortisol excretion after 48 weeks of osilodrastat usage, and additional 10% had or achieved partial control in terms of urinary free cortisol excretion. If we look here on this turquoise line, this is the dose of osilodrastat, and the red curve, this is the concentration, this is the excretion of urinary free cortisol. And we can see here that this action is really very rapid. After a couple of weeks, after 3-4 weeks, we can see that majority of patients achieved the biochemical control of excretion of urinary free cortisol, and the same happened with the serum cortisol and also salivatory cortisol. If we look at clinical parameters, anthropometric parameters, if we look at blood pressure control, if we look at blood glucose and the percentage of glycated hemoglobin, everywhere we can see the improvement after introduction of osilodrastat to our patients. The same with physical features of hypercortisolemia, and also we can see that in the questionnaires, in Cushing's quality of life questionnaires. If we turn to the possible side effects, in fact, if we see the adrenal insufficiency and glucocorticoid deficiency, this is pretty much the same. This is in fact the goal of our treatment. If we can imagine the patient with severe hypercortisolemia and the steroidogenesis inhibitor and the up-titration of the dose, at certain moment we receive the level of the drug which stops the process of production of cortisol. So in this moment, we just need to stop for a while, maybe to low titrate, to go down with the dose, maybe to introduce for a while 10, 15, maybe 20 milligrams of hydrocortisone, just to make our patient completely safe. But in fact, this adrenal insufficiency and symptoms connected with glucocorticoid deficiency, this is the goal of our treatment. I will talk for a while about hypokalemia and hypertension. This is not a very common side effect. It can happen between 10 to 20% of patients. I will show it on the example for a while. But I would like also to show for a while the next trial connected with oscillodrostat. This is Link4 study, and after 3 weeks from oscillodrostat introduction, the full biochemical control was achieved in 75% of patients. So if we compare that with results in the prospective study with metirapon or with levocotoconazole or even with pasirotate LAR, this is the real progress, and the percentage is definitely higher. The important issue is that this is the stable effect. In the rollover study, in the extension phase, we can observe the stable action of oscillodrostat even after 3 years of treatment of our patients. So the same we can see with serum cortisol and late-night salivary cortisol. So there is no escape phenomenon in our patients, and the same is with cardiovascular and anthropometric and also metabolic parameters in patients in the extension study, patients treated with oscillodrostat. If we look at the dosing schedule, in clinical trials it was easier because we had to just to follow the protocol. We started with the low doses, 2 milligrams twice daily. If urinary free cortisol was not controlled, after 3 weeks we increased the dose to 5 milligrams BID, then 10 milligrams, 20 milligrams, and the maximum dose was 30 milligrams BID, so 60 milligrams per day, and we had such patients treated with 60 milligrams of oscillodrostat. But what is important, after 6 weeks in both registration clinical trials, we achieved biochemical control in majority of our patients after something between 5 to 6, 7 weeks. So this is the time which we need to uptitrate the dose and to achieve biochemical normalization. In fact, we have 2 treatment strategies, 2 possible treatment strategies. This is titration strategy, gradual dose increase under the control of cortisol levels, either in urinary free cortisol or late-night salivary cortisol, or optimally both of them. And we have the possibility to use the block and replace strategy. In fact, we don't have any clinical trials comparing these 2 strategies. The second strategy is pretty much the same strategy which we know from Graves' disease. Yes, when we use levothyroxine plus thiamazole or propylthiouracil. So this is pretty much the same strategy. We can imagine that maybe in patients with very severe hypercortisolemia, the second strategy will be more useful, to start not with 4 milligrams daily, but we could start with the let's say 10 milligrams, then we can rapidly increase the dose to 15 or 20 milligrams per day, and we, since the beginning, can give to our patients the small doses of hydrocortisone, just replacement therapy, 25 or 30 milligrams per day. If we come back to our consensus, Pituitary Society guideline, rapidity of action, yes, oscillodrostat is a very, very rapid medication with the favorable safety profile, easy of use, twice daily, as compared to ketoconazole, 3 times daily usually. If we compare to metirapon, at least 3, usually 4 times daily, this is definitely better way of dosing this medication. Degree of likely biochemical normalization, we can say yes, and specific clinical improvement. Consensuses and guidelines, they rarely predict the future, but here in 2021, in this Maria Flescheriu consensus, authors were saying it's expected that oscillodrostat will be increasingly used as it becomes widely available, given its high efficacy and twice daily dosing. And another sentence, oscillodrostat achieves high rates of cortisol normalization. Dosing schedule may be more convenient for patients compared with metirapon. This is a Pituitary Society guideline from 3 years ago. In the hospital I work in, we have 19 patients treated with oscillodrostat, 12 of them with chronic hypercortisolemia due to uncurative previous pituitary surgeries. We had 7 patients with ectopic Cushing's syndrome. We have now 12 patients who are being treated now, and 6 of them are being treated continuously for more than 5 years. So if we look here on these six pictures, charts, we can see that in case of patient second, third, and the 6th one, everything is really is great. Full normalization, stable effect. In additional 3 patients, patient 1, patient 4th, and patient 5, also the red curve, this is the late-night salivary cortisol, the blue one, this is urinary free cortisol. Everything is going down. We achieved both biochemical control, either with the urinary free cortisol or at least late-night salivary cortisol, and we achieved the clinical significant clinical improvement, but it was not so ideal as we could expect. But anyway, in all patients, we received both biochemical and clinical improvement. Here is the example of one patient with the effective TSS in 2014 and the confirmation of corticotroph microadenoma, and the CD recurrence in 2018 after 4 years. We performed second transsphenoidal surgery, but the disease persisted. He had really very high excretion of urinary free cortisol, 24 times upper limit of normal, and the same was with the late night salivary cortisol. And here we can see that after a couple of weeks from introduction of oscillodrostat, we achieved full control of hypercortisolemia. Of course, we started with small doses, then we increased the dose, and we achieved the normalization of late-night salivary cortisol as well as urinary free cortisol. The clinical improvement was also very spectacular. But here I would like to come back for a while to the risk of hypokalemia and arterial hypertension, because this patient was taking 60 milligrams of oscillodrostat daily, so the maximum dose to control his symptoms. And several times we experienced clinically important hypokalemia, and also it was the necessity to increase the dose of antihypertensive drugs. In most cases, such situation can be observed in the beginning of treatment. And in most cases also the initiation of spironolactone or eplerenone and or potassium supplementation is enough. In this case, it was also enough. But according to clinical trials, but also real practice data, the probability is about 15% of the clinically significant hypokalemia, and also the necessity of increasing the dose of antihypertensive medication. If we look at this schema, we can see that the urinary free cortisol, this is the red curve, this is the rapid control of hypercortisolemia, but in several points we achieved really very low values of urinary free cortisol and also late-night salivary cortisol. According to data so far, we can say that the probability of the episode of adrenal insufficiency is about 25% during first year. This is similar value, 25–26% during first 2 years. But if we look at our patients treated for 5 years, the probability of at least one situation with clinically significant decrease in cortisol with symptoms of adrenal insufficiency, the probability is higher than 50%. So we need to remember that not only in the beginning during the up-titration process, but it can happen all the time. We need just to remember that. So who is an ideal patient for the treatment with oscillodrostat? We can say that, in fact, any patient with any grade of Cushing syndrome severity, and we can say also that the more severe the disease, the greater clinical benefit. Any patient with diabetes and cardiovascular disease will benefit from oscillodrostat treatment, and also oscillodrostat can be introduced in every Cushing syndrome patient with diabetes, regardless of its metabolic control, contrary to pasireotide LAR, when we can focus on the hyperglycemia before introduction of pasireotide. So what to do in very severe acute cases? Of course, we can use either this block and replace strategy, or in the department I work in, we sometimes use the combination treatment. We use etomidat in the beginning. We up-titrate the dose of oscillodrostat, and then after a week, sometimes 2 weeks, like in this case, we decrease the dose of etomidat, and the patient is stable without hypokalemia, without psychiatric symptoms. And we had several patients like this, 3 or 4, and it really worked. But of course, we need to have the access to intensive care unit to start etomidat. So it can be the option for a small group of patients. But still, Cushing's disease, of course, still constitutes a big challenge for all of us. The medical therapy plays definitely increasing role in persistent hypercortisolemia, and it should be individualized. And also further studies are needed to determine whether we can use the combination treatment in hypercortisolemia. Thank you very much for your attention. Thank you.